Hi, everyone. Thanks for coming out tonight and spending time with me. I realize that during COVID we can't meet in person, and I look forward to meeting all of you in more interactive meetings in the future. I have a true passion for Lasik and PRK, and I'm delighted to be working with the Katzen group team. It's been a lot of fun. So what I'd like to do is spend tonight talking about, now it's not moving. That's interesting. That's weird. I can do it this way then. I'm going to give you an update on refractive surgery. I don't have any financial disclosures. And we've been finding that there's been a great increase in the demand for Lasik and PRK since COVID because of fogging of masks. There's a fear of contamination of patients with their contact lenses. And basically, people are working from home. They're a little bored. They have less time constraints, and they have often have a little bit more of excess money because they can't do things like go on vacations. You may have noticed people are buying cars and boats and all kinds of things. So we've found a big demand for Lasik, and I'm delighted to be working with the Katzen team. I do like to start at the beginning, and sometimes these talks get boring if people give too much history, but I think it's nice to just go back to the basics. The excimer lasers were created by IBM to etch microchips. And it was just sort of a freak meeting by Stephen Troquel and one of the engineers from IBM. They were actually sharing a helicopter together, and they started talking about these excimer lasers and the precision of them. And the fact that they're non-thermal. So essentially, Stephen Troquel started the first clinical trials on the lasers back in the 80s. I think it was 1988. And the rest is history. I always love this old slide that just shows a human hair being etched by a broad beam laser. And as you know now, these lasers can treat myopia, hyperopia, and astigmatism. PRK was first approved in 1995, and I'm proud to say I was in some of the original trials. But as we found out it was rapidly replaced with Lasik for the majority of patients due to the speed and ease of recovery. But still to this day, we performed anywhere between 15 and 20% of annual cases by PRK, either due to the patients having some corneal issues, or sometimes for specific vocations. And the things to look the most carefully for are anterior basement membrane dystrophy, because this can often be missed. And one of the challenges we have with ABM dystrophy is if you perform Lasik, and it's happened to almost all busy Lasik surgeons, is when you lift the flap up, what will happen is that they'll cleave a plane along the epithelium, and you get a loose sheet of epithelium that comes loose, and it can be a challenge for healing. Thin corneas, obviously, we can't remove too much tissue, and we'll go into that in more detail later on. And abnormal topography. In my opinion, if you're not sure whether you should be doing Lasik or PRK, that in itself is an indication to do PRK, because abnormal topography is the greatest predictive indicator for ectasia. There are specific vocations. In the armed forces, there are special jobs. People like SEALs should not have Lasik, because they're in contaminated waters, which is another reason for commercial divers. In contact sports, I've performed Lasik on hockey players, basketball players, and with Katzen, I actually performed Lasik on one of the Ravens players. But for certain contact sports like mixed martial arts, I think it's important to stick with PRK. So if you have patients who their hobby is contact sports, I think PRK is a better procedure. Lasik, as we know, stands for laser in situ keratomelusis, and the FDA approval range tends to often be broader than we actually use. Most of the lasers are approved up to about 12 diopters of myopia, but it's very rare that we can treat above 10 or 11 diopters, because it's usually limited by the thinning we were talking about before. We try to leave a residual stromal bed of approximately 300 microns and not remove more than 40 to 50% of the corneal tissue, and involve, not remove, excuse me, involve. So we like to keep a total thickness of 50 to 60%. So as an example, if we had a 520 micron flap and we made 110 micron flap, we have a 520 micron cornea, and we make 110 micron flap, and we do a 90 micron ablation, we're going to have a residual stromal bed of 320 microns, which is 62%. Because with the flap, even though the tissue is not removed, it loses some of its structural integrity. Not all, but some of it. The example I usually give patients is if you had a beam in your house and you sawed into it a third of the way, it's going to lose a lot of its structural integrity, maybe up to a third of it. Hyperopia is approved up to 6 diopters, but it's very rare to be able to treat that level of hyperopia because we don't want to steepen the corneas. We don't want to make those corneas too prolate. We try to keep the total corneal curvature, the maximum one, to be between 46 and 47 diopters. So if someone comes in and they have 4 or 5 diopters of hyperopia and their corneal and their native cornea has, or natural cornea has, is a 45 diameter cornea, I would feel uncomfortable. Or just the other week, I had someone who came in with 5 diopters of myopia, but their Ks were very flat. They were 41 diopters, so I felt very comfortable treating that. And astigmatism, we can treat large amounts of astigmatism, and I've treated over 6 diopters before by double carding. So astigmatism in itself is not a limitation. And now using Contora, we can treat some irregular astigmatism. So the technology has changed dramatically over my tenure in the procedure. Most of that change was from the 1990s to, say, the mid-2000s. And since then, it's just been an incremental change. As we know, we've moved from using microkeratomes to all laser procedures. And in the stromal ablation, we've moved to all flying spot lasers. I presently use wavefront optimized, wavefront custom treatments, as well as topographically driven treatments through Contora. So mechanical flaps, the challenge we have with that, when the microkeratome is applied to the cornea, you basically don't get a planar flap. The flap is thicker at the edges than in the center, so it does induce some change in the refraction. And for those of you who've been co-managing patients for a long time, the other big challenge we would see was because the angle of we would create the flap was less than 90 degrees, we would see epithelial ingrowth, especially in retreatments. While it had a very good safety record, I have not used a microkeratome since 2004, because one of the challenges is unpredictable nature. This is a colleague of mine, James Davidson. He's just doing everything right. He puts on the microkeratome, starts to go, and bam, jams. And just once in a while, these will jam. So their unpredictable nature, having non-planar flaps, increased incidence of epithelial ingrowth. Most surgeons have moved to a all laser procedure. So femtosecond lasers are incredibly fast. A femtosecond means 10 to the minus 12. A femtosecond is such a short duration, it's less than the vibration of a molecule. So it's super fast. The advantages are it eliminates the need for a blade. You can make a very precise shape and depth of flap. It's a planar thickness, so it induces no change in refraction. I always do a reverse angle. So basically it's like a tongue and groove, so that it reduces the chances for epithelial ingrowth. And you can even make different shape flaps. Sometimes, in rare circumstances, I'll make elliptical flaps. If someone has a fair amount of vascular pannus from contact lenses or from Salzmann's nodular degeneration, I'll make an elliptical flap to reduce the bleeding. The flap is made in less than 10 seconds. At Katzen, presently, they have an Interlaced FS laser, which works at 150 hertz. And while this is an awesome laser and you get phenomenal results, hot off the press, this is going to be upgraded in the next few months to a different system. And it's going to be getting an FS 200, which shoots at 200 hertz. and makes a very, very precise flap. I use this thing 11 times today to do, to 11 patients today. And I just love the precision of the femtosecond laser flaps. And Katzen will be receiving an FS 200, which has slight advantages over the IFS they have now, but both of them are amazing lasers. And as we discussed, the lasers have moved from broad beams to flying spot lasers. The advantage of this is the amazing change in the quality of vision. In reality, the newer lasers don't have the same risks of creating visual side effects. I'm not saying these side effects are impossible, but with the newer laser systems, there's actually been a decrease in the average level of visual disturbances. And with the last two laser approvals, that went from having 2/3 of patients having night vision disturbances preoperatively to less than 1/3. So this is the first time in the history of the procedure where actually many patients have a reduction in night vision disturbances. That doesn't mean it's not possible and doesn't occasionally occur for someone to develop night vision disturbances. It's just much less frequent. If you had come and seen me in 2000 or 1999 for the procedure, I would have told you in order to get rid of your glasses or contacts, you're going to sacrifice your night vision. In the modern world, we just don't necessarily see that at any great frequency. And by being able to use very fast, precise lasers, we can create prolate curvatures that are amazing. These German optical physicists have really created patterns on the cornea that can really reduce optical aberration. So what the Katzen right now has an Alkon laser, and it's going to be upgraded from the 400 hertz to the 500 hertz laser in the next month or two. So for that reason, I'm going to speak about the 500 hertz laser, but the differences between the 400 and 500 hertz are not dramatic, but there are some subtle improvements. So the 500 laser is the fastest ablation time in the United States. And basically at 500 hertz, basically you ablate one diopter in 1.4 seconds. The multidimensional tracking system has to be faster than 500 hertz in order to be able to track the laser from movement. And basically the laser moves so fast that it's 10 times faster than human eye, that a patient can move their eye. So the beauty of these tracking systems are you don't have to worry about patient fixation as much. Now, you should always have your patient fixate to the best of their abilities, but if anyone inadvertently moves, the laser will track them or shut down. And why does speed matter? Why did it matter when we went from 100 hertz to 200 hertz to 400 hertz, 500 hertz? Is when the faster the laser can fire, you reduce stromal dehydration. So the faster you can treat the bare stroma, the less you have to worry about changes in the ablation pattern on the cornea. And it shortens the amount of time patients have to fixate. So that really speed does matter because it gives you a more uniform treatment. One of the neat things about the 400 and the 500 hertz is when they move this quickly, basically the pulses, no pulse can overlap over the surface of the laser. So they basically, only one out of every 5 pulses can overlap so that each pulse can have enough time to have its full effect. And what they do is place more pulses in the periphery of the cornea, because if a pulse is placed in the periphery, it's going to be an oblique shape on the cornea versus a round shape. So in order to create a better profile, they place many more pulses in the periphery. So the idea of that is you can make a wavefront optimized pattern versus the older patterns, which were truncated in the periphery of the cornea. So nowadays, it used to be you just got a laser and you went home. Now we have wavefront optimized, wavefront guided. We have Contura treatments. And I'm presently in the Alkon Innovise FDA trial, which uses ray tracing in order to measure all of the optical aberrations in the cornea. The beauty of this in the future will be it will obviate the need to do the refraction. I we'll do the refraction as a second step, but as a safety step, but actually it reduces that subjective component to the procedure. The ablation pattern is 6.5 to 7.1 millimeters in size, and it creates an outstanding corneal profile. I got to stop for 1 second. I'm laughing. I'm hiding in my office, and my dog has found me, so it's outside barking through the windows. I don't know if you guys can hear my dog, so I'm going to text my wife. I apologize and tell her to come get the dog. I don't know if you guys can hear the dog, but I'll keep going in a second. So I apologize for that. I was trying to hide so he wouldn't get that. So that's the beauty of Zoom meetings. This is also not a bad time to segue into if there's any questions that anyone has about the procedures that we've talked about so far. So we have a question from Gary. What are some of the systemic health diseases that are contraindications for LASIK? Gary, this is an awesome question. And if you don't mind, I'm going to defer from answering at this moment because we're going to get into that a little later in the lecture. But it's a wonderful question. So the outcomes from these lasers are amazing. With the wavefront optimized and wavefront guided, slightly over 93% of patients can see 20/20, and 100% of patients can see 20/40. And not in substantial number of patients see 20/16 and even down to 20/12. So the outcomes with these lasers are quite amazing. One of the challenges, a new procedure in the market is SMILE. And unfortunately, the SMILE procedure at this juncture in the United States uses a much older laser system. And one of the challenges with SMILE is that it doesn't achieve the same outcomes for 20/20, 20/16, 20/12 vision. It's about a 10% lag. So I believe SMILE is going to be an amazing technology. And I completed a clinical trial with Alkon that I can't speak about for SMILE lasers in the future. But the present SMILE laser has not really caught on dramatically due to it's not quite as precise because it's an older laser. It'd be like the equivalent of using one of the excimer lasers that we have from 1999 or 2000. It is a good procedure in Asia where they're using different laser systems. It's quite competitive, and in some instances is actually taking a substantial amount of the market share of doing the cases. But in the U.S., the reason the laser has not really caught on as much is the fact that the outcomes with it are not quite as predictable. Doesn't mean you can't have a good outcome. It's a very good laser system, but it just doesn't have the same precision as do the more modern eximers. That technology is just a little lower on the S-curve. The last approval that occurred by the FDA was for topography guided lasers. These systems are used the same laser, but use a device called a Vario to map the corneal surface. So it's a marriage between the refractive error and the astigmatism or the corneal curvature. So it's a marriage of using the results from those two tests, those two results. And this, again, was the first ever FDA approval, which not only had less visual disturbances for night vision, it was the first approval that where there was a reduction in all subjective visual disturbances for patients. So in the original approval for Contura, basically there were no patients that developed severe visual disturbances and underlying visual disturbances that were present. The majority of them were reduced or eliminated. Contura didn't catch on at first because the initial rollout was quite challenging. It was cumbersome software. The doctors had to do all kinds of basically extra measurements, almost like on on a piece of paper next to the laser, and it was very time consuming. And this technology languished for, I'd say, close to 2 years. I came for Alkon. I was supposed to be one of the surgical mentors for this. And when we first got it, I felt like I couldn't mentor anyone because I found it very, very confusing and did not use the technology a lot. And then a really super bright ophthalmologist named Mark Lobanoff basically did what often very smart people do. They took a bunch of scattered different variables, which no one else could make sense out of, and created a software package that allowed all of this to be kind of brought together. And it made the data analysis much less subjective. It was a paradigm shift in the outcomes. And while it's making those changes to make it more predictable, there was no degradation in the outcome of the visual, from the standpoint of visual disturbances. So again, it made it more predictable without any loss in this improvement. So in a recent publication, what they did is they compared topographically driven treatments to wavefront optimized, which is kind of the standard treatment almost all of us do. And there was 63% of the patients with topographically driven had 20/16 vision versus 41%. But what I really think is a cool outcome to measure is what percentage of patients have uncorrected distance visual acuity that's better than their preoperative best spectacle corrected visual acuity. So what I'm saying here is these people see better after surgery without glasses than they ever saw with glasses or contacts preoperatively. And remember, this is FDA trials initially, and this was run like an FDA trial where people were truly trying to get the best possible spectacle corrected visual acuity. And with Forsities, 36% of the patients had better postoperative uncorrected visual acuity than they did preoperative best spectacle corrected visual acuity versus 23% with the wavefront optimized. I still use both systems all of the time and they're great, but this is a neat tool to have in our armamentarium. And I tend to use it in patients who present to me who have a typical cornea, some mild irregularity in their topography, and or patients who come to me and say, yeah, when I wear my glasses or contact lenses, I have visual disturbances at night because I want to do things that are going to try to minimize those. Nothing's going to completely obviate disturbances in individuals, but you want to reduce them as much as possible. Another advantage of using this tool is iris registration. When we're like today, of the 11 patients, many of them had high levels of astigmatism. So when a patient's laying supine on a bed, looking up at the laser like this, and they're looking down at the fixation target, eyes will tend to rotate clockwise or counterclockwise. And for every degree of rotation, you lose 3% of effect of the astigmatism correction, not of the spherical correction, but of the astigmatism correction. So essentially, if someone comes in and they have a half a diopter of astigmatism, who cares? They can rotate 10 degrees. And if you lose 30% of a half a diopter, you've lost nothing. But when patients have higher levels of astigmatism, like one of the patients I treated today through Contura had 3.54 diopters of astigmatism. And we basically could treat that. We want to control that cyclorotation. So essentially, in this example here, if a patient has 2.5 diopters of astigmatism and they rotate 5 degrees, you're losing a half a diopter of effect. And that's really important if people have against a rule astigmatism, because most of my patients, I'm trying to shift them to neutral or slightly to with the rule astigmatism. An example what I gave before of 3.54 diopters, it's just that when you use Forsities, it's going to calculate a refractive error that's in 3 digits. So what are the advantages? Why do we do LASIK? Why do the majority of patients choose it? Why have I had LASIK? Because actually I've had LASIK in my left eye and PRK in my right eye, but the reason we choose LASIK is speed of recovery, comfort of recovery, and equal efficacy and safety to PRK. Matter of fact, one of the calls I had right before I got on the phone here was one of my PRK patients from today was calling up, and he actually called before I called him to say, boy, this really kind of stinks. My eye's uncomfortable. And obviously he's going to get over that, but when possible, if we can avoid that discomfort that patients will feel for a day or two, we try to use LASIK whenever possible. The outcomes from PRK, though, are awesome. The outcomes, are identical. There's actually if you look at the FDA trials, some of them are actually slightly better for PRK, but it's a photo finish. So for most people, it's not worth the aggravation. I do perform PRK using Contour, although it's not FDA approved. We just let our patients know. While I like PRK and do a lot of it, I'm not super aggressive with it. I will limit PRK to about 7.5 to 8 diopters, because I do feel when you're doing this treatment on the surface, if you remove a substantial amount of the stroma on the surface, because you create a cascade of inflammatory mediators, I think you have a higher risk of getting haze and some scarring with higher correction. So I personally limit it to 7.5 or 8 diopters. Same thing for hyperopia. I won't go over about 4 diopters, because with hyperopia, it's actually interesting because you're doing a ring-like treatment. You often will get a ring of haze if you do treatments that are too high. The preoperative workup for refractive surgery, PRK, and LASIK, it's really important to get an accurate manifest and cycloplegic refraction. And I try to compare it to old refractions when possible, but it's not actually necessary. One thing that's super important to me in pre-ops is I like to compare the manifest refraction to the topography as well, and compare how much astigmatism is present. Because sometimes we'll see patients that come in and their corneal topography will have a diopter and a half of astigmatism, but their refraction only has 0.75 or less of astigmatism. So there are some individuals that have lenticular astigmatism, but to me, because there's always a subjective component to refractions, I like to try to I understand exactly how much astigmatism the patient can tolerate. We want to get a corneal pachymetry. We get topographies, and in real estate, they always say it's location, location, location. To me, topography is one of the most important factors due to our concerns for ectasia and making sure that the map of the surface makes sense with the refraction. And it's real important to look for dry eyes and do a complete analysis of the tear film, looking at the breakup time. There's a lot of meibomian gland dysfunction that gets missed. And I think in the digital world, we're seeing more and more blepharitis and meibomian gland disease because people, when they stare at a computer, blink much less. They blink 4 to 5 times per minute versus 15 to 20 times per minute. So the meibomian glands of people are getting clogged. So we really try to clean up the surface of the eye whenever possible. So who is not a candidate for LASIK? Excessively thin corneas. As we mentioned before, we want to get a residual stromal bed of approximately 300 microns. Now, I don't think that's a hard rule. I mean, I'll do patients and leave them at 290, but we don't like to get much lower than that. And we want to have leaving a residual corneal thickness of unaffected cornea to be between 50 and 60%. Like the example I gave before, if the flap was 110 microns thick and the treatment was 90 microns, you got 200 affected out of a 510 cornea. Patients that have abnormal topography, if I'm concerned regarding the possibility of form-fruste keratoconus, I will always do PRK. Again, obviously up to a certain limit of correction. As we discussed, anterior basement membrane dystrophy, moderate to advanced dry eyes, I don't think do well with LASIK. Certain occupations, unrealistic expectations are not a good candidate for anything. And FOF is fear of flap. There are just some patients who come to you and they're just wigged out about a Lasik flap. And the whole idea of doing surgery is to give someone freedom. So the analogy I'll give patients, I go, look, if you're going to be at the top of a mountain on a mountain bike and you're afraid coming down the mountain that you might hit a tree branch, it's going to knock your sunglasses off and it's going to displace your flap, then you're not getting that freedom that you're looking for. Just do PRK. So people who are fearful of flaps, of dislocation, they're fearful they have a 2-year-old and a 3-year-old, and their life is bedlam, and they're afraid they're going to get whacked in the eye. I'll just do PRK on them. There are certain systemic diseases, and I'm very appreciative of someone asking earlier about that because I do not have that in my slides, and it should have been there. So it's a wonderful question that was asked. People who have collagen vascular disorders that are not controlled. So I will do patients that have lupus, mixed collagen vascular disease, but if they have to be well controlled and they have to have documentation of this well controlled process from their rheumatologist. Patients obviously who are pregnant, people who and people who have herpetic disease. I'm not a big fan. Anyone who's had shingles or had substantial herpetic keratitis where there's a neurotrophic cornea at all, I don't think are good candidates for that. I will operate on people who are diabetic as long as their diabetes is well controlled. But collagen vascular disorders we have to look at very carefully. There was a questionable correlation between keloids and scarring in the original PRK trials. And so it was listed as a contraindication. In reality, there is no concern with keloids. As a matter of fact, I am a keloid former and I've had surgery, so I don't have any fear about keloid formation at all. So the one I worry the most about is collagen vascular disorders. Obviously, we want to get a very careful topography map. It's important that if we're co-managing patients and you're doing the topography at your office, it's really important to make sure the topography is well-centered, because if topographies are not well-centered, it often will it'll appear to be inducing irregular astigmatism. It's really important when you're talking to patients to determine patients' expectations, discuss reading glasses and monovision. I've had surgery, but at age 63, the ship has sailed on reading glasses, and the ship is so far out to sea that basically I just wear glasses whenever I want to read. We do explain to patients the risk of enhancement. In my hands, the risk is far less than 1%, it's about 0.5%, but it does increase with higher levels of astigmatism, higher levels of myopia, higher levels of hyperopia. It's also important in counseling patients about hyperopic LASIK that hyperopic LASIK is a completely different animal. Hyperopic LASIK takes much longer to stabilize. Patients do develop visual disturbances on a frequent basis that are transient. So I'll explain to patients getting hyperopic LASIK that you're going to see glare, starbursting, and halos at night for at least 3 to 6 months, and it's possible to see them permanently. Many of the patients that get hyperopic LASIK are older patients, people in their 40s, and the first thing I'll explain to them is that when I first do this, you're going to get an overcorrection. So when it's first done, you're going to think I missed, but you're going to be happy because you can read better than we're expecting your final outcome, but some of that reading is going to go away. So it's not uncommon for hyperopic LASIK to induce some myopia for a period of time. It's important to always cover visual disturbances. And whenever patients say to me, is it possible to, I always have to say, if you ask the question, is it possible? My answer is 100% it's possible. But in reality, we don't really see as many substantial patients with diminished visual acuity or visual disturbances anymore with surgery. But at least once, I'd say every 1 to 2 years, I do see someone who's developed some symptoms. For a while, we were seeing what's called rainbow glare. where we were getting a prismatic effect in some patients. I think we found ways to solve that. It was something that was being induced through the way the raster patterns, it's hypothesized to be through the raster patterns that make the femtosecond treatment. It is important for patients to understand that there may be long-term drift. I always look at patients and say, you're 30 years old, you're a different man than you were 10 years ago, and you're going to be a different man 10 years from now. But fortunately for you, your correction's -3. So we really don't expect you to drift much. But if someone comes in, especially if they're of Asian descent and they're like a -7 or 8 myope, I will explain to them that there is a chance for some progressive myopia, that as you age, you're right, you may develop a little bit more myopia. But often that's helpful because if you develop that in your 40s or 50s, it will help you read a little bit. When patients come to the Katzen Eye Center, their time there is not that long. It's usually about an hour. I want to say that the staff is actually amazing. I want to steal Hope and Dr. Lycan, if possible, all the time. They just do an amazing job. The technicians are equally good, but almost every patient I meet there loves these two individuals. So it makes my job amazingly easy. And I know I've had the privilege of working with several of the people on the call today. And I think they have a great staff, and they represent you, because whenever you refer a patient to us, you want your patient to have a very positive experience, and everyone loves Hope and Rob. The procedure is very fast. It's less than 10 minutes. You will feel some pressure sensations. And I always explain to patients that they're going to have a steamy or misty view for a period of time after surgery. And I always say to them, your eyes are going to sting, burn, tear, be blurry, and you're going to wonder why the heck you did this and it's going to start in about 20 minutes, and it's going to last anywhere from 3 hours to 6 or 7 hours. But we do always make patients understand that it is a laser procedure. It's not a magic wand, but it's a very fast experience for the patients. Patients are informed to wear clear shields and sunglasses for protection. I want them to wear them at bedtime for a week. During the day, they don't need to wear them after the first day, except if they have small children. I do really recommend people who have especially 2 and 3-year-olds, to wear their goggles or shields during the day when they're around their children for the first few days. It's normal to have a foreign body sensation and tearing, as we discussed, for a few hours. And some people will even have a little bit of a gritty sensation for a few days. I'm a big fan of getting on top of pain control. So we give patients some NSAIDs before surgery, and I tell them to keep using them after surgery. But the visual acuity we expect to be quite good on the first day. We expect 20/20, 20/25. It's very rarely in the 20/40 level. I'm also a humongous fan of using tears. I think especially in a digital world where patients aren't blinking, it's important to be using massive amounts of lubrication. I like to let me see what the next slide is, but this might be a good place to take a break. Actually, let me do this one last slide. In the majority of our patients, especially I practice mostly in Washington, where almost everyone's job requires them to be on a digital device for over 8 hours, computers, phones, tablets, and gaming. So as we mentioned, it reduces the blink rate from about 12 times per minute to less than 5. So basically everyone gets a digital dryness. So now you've got a patient that's got a neurotrophic cornea for a few months from the Lasik procedure. They've got a digital dryness. In the winter months, you have HVAC systems, you have environmental dryness, and some patients have maturational dryness. So I always sit with patients and say, you've got a cluster of different things to create dryness, and it's really important to use tears. Let me take a break here. It's always hard in these virtual meetings to kind of gauge the audience and when to ask questions. I'm looking forward to being able to do this live in the future, but let me answer some of these questions. Excellent question from Joanna. Do you have a limit of how flat the cornea should be post-LASIK? Excellent question. And because of the more modern profiles that we make with the corneas, I'll go into the mid 30s, like 35, 34 sometimes. It's not a problem. I have less of a concern of how flat I'll limit the cornea than I do of how much I'll steepen the cornea. But I don't like to see corneas in the below like 34-ish range. I've operated recently on cataract surgery on 2 patients that had RK whose corneas were in the high 20s, like 29, 28. And I don't think they basically, their cornea had become like a tabletop. It's as flat as a board. So I don't advocate flattening below, say 34 or 33. Next question's from John. Can you use the upgraded Alkon laser to treat recurrent corneal erosions due to? Basically, you don't need the upgraded laser but any laser can actually, first of all, this is an excellent question. But in reality, an upgraded laser doesn't help at all. The lasers help. But ironically, this is a case where lasers are still not as refined as Mother Nature. Bowman's layer creates an amazingly smooth surface. So our epithelial, the hemidesmosomes and anchoring fibrils have to lock in to Bowman's layer. So when we do a laser procedure, actually, and we obliterate Bowman's layer, the underlying stroma, while smooth, is rougher than Bowman's layer. So what creates the adhesion for recurrent erosions is actually the fact that we make the surface rougher. So it's an excellent question, but in reality, whether it's an older laser or a newer laser, all of the lasers work well for that. Next one is from Bryce. I haven't had any patient come in with complications from SMILE. What should we be on the lookout for? Would epithelial ingrowths still exist? Well, SMILE is a good procedure. Epithelial ingrowth, again, the question, could epithelial ingrowth occur? It's possible, but the risk of epithelial ingrowth with both SMILE and with modern femtosecond lasers is very, very small. I think you got small and smaller. They're both crazy small. The concern we see with SMILE procedures and the few that I've managed with complications, and again, SMILE, I'm really not here to badmouth SMILE at all. SMILE has a role, it works well, but what happens in SMILE is the system they presently have has a single channel, and you have to pull the lenticle out. And when you pull the lenticle out, sometimes there's a teeny bit of lenticle that gets left in there, and you have to reach in manually and take it out. But the surfaces of where the lenticle are, the anterior surface and the bottom surface, are just not as smooth. So complication-wise, I would say actually with SMILE are probably less. I'm not saying there's a procedure that has no complications, but SMILE, you don't have to worry about a displaced flap. You don't at all. You don't have as much of a neurotrophic cornea. So there are many advantages to SMILE. In the procedure, the challenge is that the underlying laser used in the present SMILE just doesn't lay down an ablation pattern that's nearly as smooth as the 500 or even the 400 hertz lasers. And that's why, you know the old adage, if you build a better mouse trap, the world will beat a path to your door. There's not that many SMILE lasers in the United States. If SMILE worked great, we would have a SMILE laser, because I could basically get a SMILE laser given to me. But I'm really not going to bash it. I just think it's a good technology, but I don't think it has quite the precision right now that we see with Lasik. Now, if I were to look into the future, 5 years, 10 years, I think SMILE was going to replace Lasik the same way PRK has been replaced for the majority of patients with this. So SMILE has a bright future. It's just not with this laser system. Benefit of doxy against MMP9s and meibomian gland dysfunction. Why isn't? I haven't seen, Bryce, it's an excellent question. I just haven't found this to be a big issue with Lasik. And In PRK, I'll often put patients on doxycycline if they're healing more slowly, but I'm just not a big fan. I'm a big fan of homeopathic treatments. I think patients should be on omega-3 supplements. I've moved away from fish oil to algae oils for sustainability, lid scrubs, warm compresses, but I'm not a big doxycycline fan. In the general population, there's definitely a role for using it in patients, and I probably prescribe, but I don't use it on a routine basis. One of my partners uses vitamin C. He thinks that it may help as well, but I have not seen a role for that. Is there an age limit? An excellent question, Julia, and I did not bring up age limits. I'm gonna go low and high. Some of the laser systems are approved at 18, I believe, but most are 21. And the reason I don't even know if they're approved at 18 is I'm really not a fan of doing LASIK in really young people. I do mostly 21, 22-year-olds because I'm looking for refractive stability. There are rare circumstances where I've done people on the young end, because if they're leaving for the Peace Corps or they can't wear contact lenses and they're doing sports. On the older end, this is where you're going to get a lot of different opinions from patients and not patients, from doctors. I'm not a huge fan of LASIK in after like the mid 50s. I think just as people start to lose, they don't have refractive stability in their teenage years. In your mid 50s, I tend to move away from LASIK and PRK and move more into refractive lens exchange, especially for hyperopes. For myopes, I'll do some, but for hyperopes, I don't like it in the mid 50s because it does induce a little bit of aberrations on the cornea, so that when patients are going to get cataract surgery in the next 5 to 10 years, they're going to see some challenges. So on the upper end, mine moved down. I used to do people in their 60s and their 50s, but I tend to, in the mid 50s, I just tell people to look towards refractive lens exchange. But I also don't want to give a mixed message. I don't do a ton of refractive lens exchanges at this time because we're going through an amazing renaissance of the technologies for implants. So I think within the next year or two, there's going to be more stability there. But in this, at this juncture, I usually tell patients that they want refractive lens exchange to kind of kick the can down the road for a year or two. And I show them my glasses and I go, look, I've got baby cataracts now. I see 2015, but I'm not doing refractive lens exchange. And I hate my glasses because I'm going to wait for the next lens. I think we've covered the questions. Oh, my apologies. I'm not reading the questions, so I didn't realize you can't see the questions. My ignorance, again, I'm not the world's best Zoom, so I should have read the questions. I apologize for that. So what systemic medications are contraindicated for having LASIK, and how long would a person need to be off these medications to be a candidate? So some of the medicines is the use of Accutane. And for me, Accutane, you should be off it for a while being at least 6 months to a year, because Accutane is one of the few medications that I absolutely have seen refractive change with. So I will, if anyone's on Accutane, presently on Accutane, I tell them to finish out their course, that, you know, there's obviously a need for your Accutane, and finish that out and then take a break. If people are on Imitrex, you really shouldn't have the procedure. You should have them off of Imitrex. That one you really don't need to be off of for a very long period of time. I just usually tell them to stay off of it for several weeks and to not reinstitute the use of it until at least for a month, because I want to make sure the cornea remains clear. The only other medicine, I'm sorry, it's been a long day, I'm trying to think. It's very rare for this age group, but I'm blanking on the name of it, that gives you cornea verticillata. Amiodarone, Corderone. If someone's on that, they should be off of it as well. So what I'd like to do now is move into the postoperative regimen. For our patients, we like them to be seen on the first day, around a week, and around a month. And we start an antibiotic and a steroid drop. At the present time, we're using moxifloxacin and loteprednol. And we have the loteprednol used very, very frequently, about every hour for the first day, every 2 hours for the second day, and then 4 times a day for a week. I often will add a second week of loteprednal at twice a day, especially for higher corrections and or in winter months when there's a lot of, and anyone whose eyes look dry, a little more steroid is actually helpful for healing the ocular surface. The antibiotic you need, you probably only need 2 or 3 days. We tell them 5 to 7 days, but I truly am a big fan of using tons of tears. So basically, I like to keep things simple, and we use just an antibiotic and a steroid. For the first few days, we're using the antibiotic very frequently, and then we just go to 4 times a day for both, and then maybe twice a day for a little bit longer. If you're looking at a patient and they still feel like their vision's a little blurry at a week, or their eye looks a little dry, loteprednol is very well tolerated. It's very, very rare for it to induce a pressure spike within the first month. In the FDA approval of loteprednol, they looked at use QID for 90 days, and the rate of developing ocular hypertension was less than 1%. So keeping someone on loteprednol for a few weeks after Lasik is not a bad thing. I've done it before. And the reason it's important when we talk about this versus PRK, obviously, while they're on this loteprednol, no one's taking the pressure of the eye because of the tonometry would be contraindicated. But even in patients who I've done Lasik on probably over 50 people who are on glaucoma medicines, and I really don't worry about having them on a steroid drop for 1 to 2 weeks. Obviously, if someone had markedly advanced glaucoma, that's a different process. But if someone has, most people can tolerate even if they get a little bump for a week or 2. As I said, we usually see patients at 1 day, 1 week. The 1 day has to be 1 day. 1 week is around a week, around a month. I usually like 3 months and around a year. At all of these visits, I joke with them and say, we're basically, most of the reason you hear is for me to nag you about using artificial tears. What you should be doing is looking to see how much dryness they have, obviously taking the vision, looking at the flap, making sure the interface, there's no signs of epithelial ingrowth, which again is extraordinarily rare in the modern world, and just looking at it for dryness. And I also am now looking at people to see whether they're developing blepharitis. As I said, I think there's really been sort of a huge increase in the frequency of blepharitis over the last decade or so because of all the digital screen time. There are many complications that can occur from Lasik. Fortunately, they're very rare, and many of them can be avoided with close attention to detail. Since we no longer use microkeratomes, getting a buttonhole is extraordinarily rare. In fact, I've never had it happen. I feel, I'm always superstitious. I feel like by saying that it's going to happen to me, but most of the time when you get a buttonhole, it's because of the old microkeratomes that you would get a loss of suction so that you would get a cut right across the cornea. But what you can see with femtosecond lasers is when the raster pattern is laying down, when the bubbles are being formed and laying down a raster pattern, if there's a break in that pattern, you can get an area where the flap is stuck. And there have been rare circumstances where people go to cleave in that plane and they tear the flap. So buttonholes have been replaced with flap tears, where you just basically cut like a line in the flap. It's extremely rare. It has not happened to me in over 10 years. And if it happens, it's not the end of the world. You just kind of put everything back. You put a bandage lens on. and then you don't do anything for quite some time. I like to wait at least 3 months. But again, it's extraordinarily rare. The things we see with flaps are you can get wrinkles, you can get interface debris, you can get edema, shrinkage, some bleeding, epithelial complications, and you have to pay attention to detail. So displaced flaps occur usually within the first several hours. We say within the first 24 hours, but almost all of the patients I've seen this with will have had a displacement within the first 3 hours. And often what happens is patients will relay a history of they went to sleep, when they woke up, they felt like a stick and their flap displaced. Risk factors for this are dryness, trauma. Obviously, I've had people have their flaps displaced from poking themselves in the eye, falling asleep without their goggles, rubbing the eyes. Fortunately, this has very good outcome. We basically will bring the patient back into the office. We will remove the central epithelium, refloat the flap back into position, place a bandage contact lens onto the eye. And sometimes I'll even add punctal plugs if I feel the person's really dry. When this occurs, the patient's recovery will be much slower. I tell patients it's sort of like a modification. It'll make it closer to PRK. They're going to have discomfort for a few days, but their visual should recover back to a good range within several weeks. The key with this, though, is telling patients to temper their fears that something's permanently wrong in the first week or two, because most of the time when you have a displaced flap, it's in one eye. So patients are often comparing the displaced flap eye to their other eye, and there's a level of anxiety, which is not inappropriate, but you have to explain to them once we remove the skin cells, it's going to take quite some time. Bear with me for a second. I'm just going to take a sip of water. Sometimes you'll see patients, though, and you can see some wrinkles at a week or a month or later. When patients come back in, it's very, very rare. But if these wrinkles are in the periphery, I really don't do anything about them. If they're in the center and affecting vision, they can be repaired. But one thing you've got to remember is when we do LASIK on high corrections, almost all of the patients, when they come back to see you, are going to have a very fine wrinkle pattern throughout the cornea. And the reason for that is, if you think about it, you have a flap and it's like an arc. Then you've got the tissue underneath and you've removed some of that tissue. So now you're laying a flap down that's of larger size than the bed. So it's actually got there's more space through this arc than there was in the bed. So you're going to get little micro wrinkles throughout the flap. Those tiny micro wrinkles don't affect patients at all. This slide here is not micro wrinkles, that's stria. That's a patient that came back at a week. So obviously they either rubbed their eye or something happened, but in this case, we can go back and do the same steps. We can remove the epithelium, refloat the flap, and iron the flap out and put a contact lens on. Epithelial ingrowth usually occurs right after surgery. It's of increased risk whenever there is a flap complication and an enhancement. But in the modern world, as I said, I use a 120-degree flap as my angle, my cut. So again, mine's like a Z. So the flap actually folds in, bevels into the bed. Actually, the bed of the flap folds into the side there. So essentially, we just don't usually see epithelial ingrowth anymore because the epithelium has to come from the surface, go underneath, and go all the way that way. When we used to have like a very fine slope, it was easy for cells just to slide down. If it's just in the periphery, you observe it. If it's significant, you can lift the flap back up, scrape it out. And it is important, if it's significant, to remove it, because a large sheet of epithelial cells actually block the transmission of nutrients from the aqueous and the cornea that the deeper cornea to the surface, and you can get melts over it. And I've seen that. Fortunately, not in one of my patients, but I've seen it in consultation. But not for quite some time. DLK, or sands of the Sahara, is an inflammatory process where the cornea gets white blood cells in the interface. It usually occurs within a few days after Lasik. It's felt to be usually due to contaminants and sterilizers, allowing bacterial endotoxins to get inside the surface. In reality, we just don't see it that much in the femtosecond world. I can't recall the last case. There was a lot of speculation that it actually was coming from the fine solvents placed on the metal blades, because we saw more DLK when we used blades, and but we also did see it in some of the early femtosecond lasers where a lot of energy was supplied into the cornea. But if you see this, basically you have to lift the flap up and you irrigate it out. You use a lot of topical steroids, and it should not create a problem. But if there's any question about whether there's any sands of the Sahara DLK, have the patient seen immediately, because you can get some melting on the undersurface of the flap. It can be difficult to tell subtle DLK from a subtle infection. Now, obviously, this is a bad infection, but when you can get an infectious keratitis with Lasik, because of the bacteria are underneath the flap, they're camouflaged or blocked from the surface enzymes and white blood cells, so they can percolate down there and grow pretty seriously. In this circumstance, we do a flap lift, we culture, flush antibiotics underneath the flap, and sometimes even use systemic antibiotics. But fortunately, in the modern world, with the use of good hygiene by our patients, with third and fourth generation fluoroquinolone antibiotics, we just don't tend to see a lot of infections. But it is always something to be vigilant for, and it can be quite devastating to patients. Ectasia is basically the bane of the existence of all LASIK surgeons, because we really don't understand what causes it. Essentially, we don't have it figured out completely. There are risk factors: having a thin cornea, having a very high correction, being young at age, but the most important one is an irregular astigmatism. So if patients have any of these risk factors, I will tend to lean towards PRK. We've discussed how much residual stromal bed to leave. The incidence is very variable in multiple studies, anywhere from 1 in 2,000 to 1 in 5,000. I don't think we see it at this incidence anymore, but I basically had a case in 2016. We saw them back in 19 that developed that. So there are circumstances where it can occur, but it's very, very rare in the modern world. But we don't really completely understand what causes it, because they've looked at huge analyses of patients. There was a study done in Europe where they looked at over 100,000 Lasik procedures, and then they looked at which patients developed ectasia. Then they went and looked at those patients, and of those patients, some of them had these risk factors, some of them had no risk factors. Then they went through all of the patients that did not have ectasia, and there were a variety of patients that should never have had surgery in the first place. They either have too much correction, irregular astigmatism. There were things in some of the patients that didn't develop it. So we really don't have this one figured out completely, but we can only do the best we can. And these are the risk factors we look at now. In PRK, which some people now call advanced surface ablation, you're going to have an epithelial defect. We place a bandage contact lens for 5 to 6 days. I tell patients that they're going to have discomfort for 2 to 3 days. The one thing I have found with the patients is I counsel them saying, look, the one thing about PRK pain that I found quite tolerable was it goes away 100% of the times. There's few things I can tell you with 100% confidence is pain from PRK goes away. So I say, look, you may, if we do surgery on you on Wednesday, you have a 100% chance it's going to be gone in several days. So to me, that made my postoperative experience easier because I knew I just kind of had to put my big boy pants on and kind of suck it up for a few days and it would go away. I'll use slightly different language. That's the language I'll use with some patients. Some of them I just say, you know, it's going to go away. It is important to use pain medicine. We tend to prescribe Percocet. I tell patients to get on top of their pain. We have all patients, we advise all patients to take a Percocet before they even leave the office. It's very important for them to have adherence to their anti-inflammatory regimen. I tell patients to think about their steroid drops like oxygen. They can't live without it, because some patients will lose their bottle or the bottle runs out and they'll abruptly stop the steroid. So we really have to drive home the importance of adherence to that anti-inflammatory regimen. But the key thing with PRK is setting reasonable expectations of how it's going to be blurry for a few weeks. It's like having a dirty contact lens. Because some patients, what happens is no matter what you say, they think when you take the contact off at 5 days, they're going to see like as if they had Lasik. So I basically bluntly say that to them when we talk to them and we're counseling them. I say, look, you know, when we take the contact off in 5 days, you're still going to be blurry. You're going to be able to function. You should be able to go to work. You should be able to do your job, but it's going to be like functioning through a slightly misty pair of glasses or a slightly dirty contact lens. And it's going to take at least a month to 3 months for the curve of the PRK curve and the Lasik curve to meet up. So you're going to go through a slower recovery. And by saying at least a month, most patients catch up faster than that. But you always want to set an expectation bar where you're going to jump over it easily. And the higher the correction, the longer it's going to take for those two to even out. We use an antibiotic and a steroid drop. The steroids should be tapered over 1 to 2 months. I tend to vary the steroids based upon the level of correction and how much epithelial healing has occurred. So people who are healing slower, I'll keep them on steroids longer. But a good rule of thumb for me, say someone that was a -5 would be using Inveltis or Predforte 4 times a day for a week, then 3 times a day for a week, then twice a day for a week, then once a day for 2 weeks. If it's a higher correction, I'll taper them slower, and I'll even take them and put them on a weaker steroid like loteprednol for several more weeks. I'm not a big fan of using dilute proparacaine. I'll allow patients to use it for the first few days, but I tell them it's usually kind of like a drop in the bucket for the discomfort. Typical recovery is discomfort for 3 to 4 days, having some wide fluctuations in the vision, and then smaller fluctuations for several months. The key with these patients to reduce the risk of developing glare, not glare, excuse me, of haze, which can create glare, is making sure you get that surface healed. Sometimes you'll see PRK patients who the epithelium's healing, but it still looks boggy in the middle, and you'll often see like little Y lines where the epithelium is coming together, but it's not sitting perfectly. In those individuals, you really have to work hard. You have to lubricate them. If it bogs down and stays like as loose, sort of irregular epithelium, sometimes I'll even, it's unpopular to do it, but I'll even scrape it off and just that little area, and then I'll put on an amniotic membrane graft. But if there's any epithelial irregularity, please have them come in and see us. We're delighted to see the patients at any time. But the recovery for this is just slower, but the results with it are amazing. We usually see them at 1 day, 4 to 5 days, 1 to 2 weeks, and then every 1 to 2 months. Watch the IOP. I usually will start to check the IOP at the 2-week visit or the 4-week visit. At the 2-week visit, if the epithelium looks awesome and it's healed up, I'll check it there. But if you're not sure, just wait 1 more visit, do it at the 4-week visit. Be careful of steroid responders. I'm a little, while I'll do Lasik on patients with glaucoma, or with well-controlled mild or moderate glaucoma, I'm always a little hesitant to do PRK, because you don't want to get into the circumstance where someone's a week or two out, and all of a sudden they come in and their pressure's 43 on steroids, because you can't stop their steroid and they're already on 2 medicines for their glaucoma. It can kind of be a mess. So I'm not a huge fan of PRK in patients that have moderate or advanced glaucoma. If they're on 1 medication, I would do it, but not if they're on 2 or 3 medications. And really, I try to do Lasik on as many of the glaucoma patients as possible. As I just started to mention, if you see persistent epithelial defects, you really got to jump on them. This is the thing I worry the most about. Risks for that are prolonged use of mitomycin C at the time of surgery, older patients, diabetes, and toxicity to the preservatives or the medications in themselves. So in these patients, I tend to like, in PRK patients, I like to use preservative-free tears longer. There is a risk of regression in haze, so it's important to keep the epithelium as vibrant and healthy as possible, because if you have irregularity there, you will have a higher risk of regression. Things to help with lubrication: punctal plugs, bandage lenses, amniotic membrane grafts, tears. Someone mentioned earlier doxycycline, and doxycycline is an excellent medication. In this circumstance, if someone's having issues with PRK, I'm a big fan of doxycycline. I also try to find out how much screen time they're having. And the people I worry the most about are, and Rob and I just managed somebody with this recently. They didn't have problems, but he's computer programmer by day, gamer by night. So this guy basically sits on a digital device for 16 hours a day. So I basically told him the importance of using artificial tears on a very, very regular basis, and basically told him to cut out or reduce his gaming for a few weeks till he got further along in his healing. Corneal haze can be kind of challenging to treat. When I was a young doctor, I remember at Wills Eye Hospital, I went to one of the attendings and I said, I'm looking at these patients, Dr. Labson, and how do you tell haze from scarring? And he went, time and not clearing with steroids. So essentially, you can't tell in itself whether it's scarring or it's haze. It's just you want to not allow haze to become scarring. So what haze is basically the keratocytes in the cornea are putting out glycosaminoglycans, and they're compromised, they're stressed. So instead of putting out the appropriate types of glycosaminoglycans, they're putting out a cloudy, kind of crappy substance. So basically the ground substance of the cornea becomes hazy because the keratocytes are pumping out kind of lousy gags. So the reason that, the way you help, the reason steroids help is what steroids do is that what they basically do is help heal and stabilize the membranes of the keratocytes so they can put out the appropriate glycosaminoglycans. So basically when this happens, I bump up steroids. In rare circumstances, we've had to use mitomycin, but I try not to because if possible, and in very, very rare cases, we'll do repeat PTK, PRK. Anecdotally, I had a patient a few years ago who basically, he was a really good guy, a great guy, and he was super compliant. And he just started to develop haze and it wasn't getting better. I shouldn't say it wasn't getting better, it wasn't getting better fast enough. And we had to treat him with steroids. We did everything. He was doing everything right. And he was getting better, but he was getting better slowly. And then he said, he goes, hey doc, I'm going down to the beach in South Carolina, Folly Beach, for a couple of weeks to take a break. So I was worried about him. I said, good news. One of my good friends, George Waring's down in Charleston, and I want you to see George halfway through your trip because I want to make sure you're not getting worse. And what ends up happening is he goes there and he hangs. I go, what are you going to do when you're there? He goes, I'm going to basically, he's a lawyer. He goes, I'm going to sit on the beach. I'm going to drink beer and read books and take it easy. And so he goes down and sees George after about 10 or 12 days there. And essentially he had no haze. So George calls me up and goes, I cured your patient. I go, what did you do? I said, I examined him. So what had happened is basically this guy, he said examined me, joking. What he basically happened is him getting off of all of his digital devices, chilling out for a couple of weeks, basically cured him. And I had one, so basically when you see a lot of this, try to get your patients to reduce their screen time. You're going to get them to stop working, but try to reduce the screen time, increase their lubrication, increase their steroids. And if push come to shove, send them to Folly Beach for a couple of weeks to drink beer, and maybe they'll solve it for them. But the idea is to reduce the environmental stresses. Infection is very, very rare, but it can occur and it can be devastating. Risks to this are dry eyes, bandaged contact lenses, and persistent epithelial defects. And treatment is just similar to Lasik, that you're going to culture and use antibiotics. The only difference here is because you're treating on the surface, it's a little easier to treat these. So in a nutshell, what to look for is check the vision, check the refraction, report back to us if there's any unacceptable or unexplained visual symptoms, get the surface healed as quickly as possible for PRK and Lasik patients. If there's anything you see that you're just a little uncomfortable with, send them in. We always will make you look like a hero when you do that. We're going to say, Dr. X took a look, there was some concern, and the good news is when we're looking at this, we give them a course and say it was great of him or her to get you in to see us right away. And there's a plan of action. We're going to work together as a team, and we're going to get you where you need to be. We're delighted to see anyone at any time. On the first slide of the presentation was my cell phone number and my email address. Feel free to contact me about any patient. I also what I'll do after the surgery is I'll text you and let you know how your if I can get your cell phone number and you don't mind, I'll text you and let you know how the patient did. And feel free to follow up with me at any time. I want to make life as easy. I don't want to create any barriers to you to be able to communicate to me directly. So in summary, the range for treatment for me is usually around a half a diopter to 10 or and occasionally 11 diopters for Lasik, up to a little bit, not quite that steep for PRK. And again, based upon the questions of the corneal curvature, because there was an excellent question asked, how flat will you allow it to become, or how steep will you allow it to become? And that does play a role. When we do some of the customized treatments like Contora, you will remove more tissue with Contora than you do with a standard treatment, so it will also play a factor. Hyperopia, I very rarely go above 4. I'm a big fan of very low levels of hyperopia. And, but I don't think the surgery is great for everyone. See, me, you got to have many, many tools in your toolbox. Not the old adage, if all you have is a hammer, everything's a nail. To me, if I see patients and I think that they're not an ideal candidate, I'll explain to patients there's other options. There's phakic IOLs, there's refractive lens exchange. And because in reality, for very high corrections, whether these are, I think intraocular lenses are better options. The Visian ICL is undergoing a change. There's a newer model that has a fenestration in the optical zone. Excuse me, not the optical zone. Yes, in the middle of the optical zone. It will make the lens have a little, so you don't have to do a peripheral iridotomy, but it also reduces the rate of cataract formation. So at the present time, I am not doing ICLs because the newer version is going to be out soon. So to me, it doesn't make sense to use an older version when there's a higher risk of cataract than there is in the newer version. So I just ask patients to sit tight with that. As I really feel great to be part of the Katzen Eye Group team. I really look forward to working together. Living in Annapolis, I can shoot to DC and see patients with eye doctors in Washington. I can shoot up to Baltimore and see patients. I am a huge fan of constant communication. As we start to work together, you'll find that I tend to text you from time to time. I'm not gonna really be, badger you and ask you things, but I'll text you, let you know how things are going. And I truly have a commitment to your patient satisfaction. I've been blessed to have a long career in refractive surgery, operating on everyone from people in the White House who I can't tell you who they are, to Stanley Cup winning goalies. But most importantly, I've had the surgery myself. I've done it on my children, on my brother, who I like, and many of the people at Katzen have also had surgery. And we look forward to continuing to work together, and I look forward to working with you. So for co-management, Hope is just, you cannot do better than Hope. She helps with lead management and coordination and communication. Rob Lycan is amazing to work with. There's free consultations, there's perioperative testing, there's perioperative care. So I am looking forward to working together. I've had the opportunity to work with one or two of you and look forward to doing that more in the future. I wanted to ask answer some more questions. There's a question from David Reed. Do you feel there's a role for Restasis, Sequa, Xiidra pre, peri, and postoperatively? So yes, yes, and yes for all of these, of all three of the meds and for all three conditions. These medicines are very expensive. So I don't tend to start them preoperatively on everyone. If I feel a patient would benefit from using them, I will start them. But if I'm going to start these medicines, I don't think you should do surgery right away. I think that you should wait at least a month. If a patient is dry enough that you feel you can't control them on with their present regimen, and you're adding a anti-inflammatory modulator, whether it be Lefidogras or whether it be cyclosporin, make sure there's sufficient time for it to work, and a month is a minimum. More mistakes are made in medicine, including mistakes made by me, by people doing too much too fast than too little too slow. So with patients, I'll just say, look, if your eye looks drier than we like, I think we've got to get the surface in better shape, because surgery is going to be a stress on your eye. So I'll start those medicines, wait at least a month or 2 months. If patients are on those medicines already, I will use them. But usually in LASIK patients, I will have them stop that agent for the first week. I think sometimes it's challenging for patients to be on too many medicines. If they're on Restasis twice a day, Lotemax 4 times a day, moxifloxacin 4 times a day, and tears, they're more likely, not more likely, there's a substantial chance they're going to make a mistake. So I just stop the dry eye medicine until we take them off of the steroids, and then I restart it. So my feeling about it is a week or two off is not going to matter because they're already on an inflammatory mediator. If I'm going to start a medicine and it's affordable to the patient, I usually use Xiidra, because as you're well aware, Xiidra works on both the active T cells as well as stopping T cells from being activated, where the cyclosporin only stops or reduces the release of T cells. I'm sorry, been a long day. So what I'm getting at is, if I'm going to try to quiet somebody down, if you're using Xiidra, you're not only knocking out the beehive, you're knocking out the live bees, the bees that are flying around. Or if you use Sequa or Restasis, you're just knocking out the beehive, but those bees are still going to sting you for a while till they die. So to me, if you're going to start something and you're trying to get surgery done, I'll usually use Xiidra as long as it's tolerated by the patient, because of the side effects. As you know, some patients get a lot of burning, they get a funny taste in their mouth, and they can get blurred vision. It's always a little hard to do these virtual meetings because you never really know when to slow down or when to speed up and answer questions and do things. But it's truly a privilege to be able to work with my colleagues in the Baltimore community.